Dear colleagues, first of all, I have to appreciate very much the invitation to this fascinating meeting. Thank you very much. My talk will be not scientific. I will just show you some small tricks how we treat perifoveal telangiectasis and central serous chorioretinopathy. I will skip the epidemiology because I think that the next speakers will talk about that. We all know the multimodal imaging, and this led to recent findings such as the introduction of the term pachychoroid pigment epitheliopathy or diffuse retinopigment epitheliopathy. In ideal cases, the CSC is a self-limiting disease, but in 15 to 50% it recurs with the worse final vision. So we can use for the treatment either the classical laser coagulation or using special instruments, the pattern subthreshold laser, or what we use is the stimulation laser, which we call threshold or subthreshold. We know the results of studies with half-dose PDT or half-fluence PDT, and up to now, medical treatment is not very convincing. But we know the mineralocorticoid hypothesis, which shows that central serous chorioretinopathy has something to do with hypertension, coronary disease, psychological distress, ischemic stroke, erectile dysfunction. So it's a more diffuse vascular dysfunction. And I refer to a very nice article written by colleagues from the University of Lausanne, published in Progress in Retinal Eye Research. From this mineralocorticoid hypothesis comes the newly introduced treatment with spironolactone, which however has side effects, and eplerenone, and studies from 2013 and 14 have promising results. But as usual, further studies are needed. So to summarize, I can say that central serous chorioretinopathy still is a mysterious disease, as Professor Sylvia Bob said at the EVRS meeting 6 years ago. And because it is a very individual disease, we should try individualized treatment for the benefit of our patients. And for that, we use the combination of traditional procedures and experimental ones. So we all know the classical focal laser with direct photocoagulation of the focus. That's very easy. And usually spot is used for that. But we can use also the threshold or even subthreshold spot. And we call this laser stimulation therapy. It can be beneficial even in cases without the typical focus of leakage. And I can show you 16 patients where it worked. Just anecdotically, we succeeded with topical steroids, which are usually rejected for CSC, but they seem to be useful in 2 cases. But in our experience, anti-VEGF injections did not show any benefit. So we analyzed this group of 40 eyes, 34 of which were treated with the classical thermal laser here. And out of them, 18 eyes had the typical focal leakage. So we treated them where the focus was clearly defined with focal laser, even in eyes where the focus was juxtafoveal. Here we used threshold energy, such as you can see here. This is juxtafoveal lesion, and after the laser treatment, which was very easy, the patient healed. This is another case where it was more complex. You can see mottled hyperfluorescence, but still we can guess that the focus of leakage is here. We treated the focus and the patient improved. He lacked metamorphopsia, and still you can see that the laser spots are not visible. And now I will show you 16 eyes where the focus really was not defined. It was either anticipated, so we applied threshold or subthreshold laser into the anticipated focus, or the leakage was really diffuse or multiple. And here we stimulated the area with the laser because we believed that it will lead to the activation of the retina pigment epithelium, which leads to the sealing of the area of leakage. So we applied a stimulation laser to the weakened areas of pigment epithelium defect. What is interesting for you that we do not use any special laser for that. We use just the classical retinal laser, 532 nanometers, and a small spot, 100 micrometers or even smaller, duration 100 milliseconds, and energy 50 milliwatts. The technique consists first tuning of the energy. First we make a visible spot away from the arcades, then almost invisible spot close to the macula or close to the fovea, And then if we need to go to the fovea itself, we use invisible spot. Usually we use 5 to 10, maybe sometimes 15 spots. And this is a case report, 54-year-old female. She had 30 months metamorphopsia from this detachment, and her vision was 0.5. We applied subthreshold laser to this area, and you can see that the laser spots are not visible, and she improved. Her metamorphopsia was gone, and she was very fine. A similar case was this. She had vision 20/20, but she suffered from metamorphopsia. After the stimulation of this area, she lost her metamorphopsia. This was a man who had second attack of CSC after 3 years. The second attack lasted 4 months, and we treated this unknown focus. And you see this subretinal fluid almost complete, and he had only minimal residual metamorphopsia, and the laser scars are not visible. This lady had bilateral disease. First she came in 2009, and she had this detachment, neurosensory retina detachment, and we performed fluorescein angiography, but perhaps in the day of the fluorescein, she temporarily healed because there was no leakage seen, and she did not suffer that much. What was interesting, that she did not have metamorphopsia in this stage, but during the time the subretinal fluid reabsorbed, and when it was almost reabsorbed, she began to suffer from metamorphopsia. So we treated that known place, that faint hyperfluorescence with stimulation subthreshold laser, and 1 week after the laser she felt great improvement. She lost metamorphopsia, and she was very happy, and this is after the laser treatment, a very small defect in the pigment epithelium. She came 6 years later with 5 months lasting metamorphopsia in the other eye, and she had again serous detachment and undefined focus of leakage. So we treated all this area with subthreshold laser. 1 month later she was slightly better, and 3 months later she was perfect. She had no metamorphopsia, her vision was 20/20, and there was not subretinal fluid, and there are no laser spots visible. So both eyes benefited from the stimulation subthreshold laser. As I mentioned, we used anecdotal cases, so this doesn't mean anything, but it was successful. This man was in a hurry, he could not undergo the fluorescein, he was leaving to a spa, so we gave him a bottle of dexamethasone drops. He applied it every hour, and within 1 month he completely healed. Anti-VEGF, as I said, did not bring effect in our patients, neither triamcinolone. So laser treatment was followed with a complete, or at least partial recovery, not only in cases of focal treatment of the leakage point, but also in most of the eyes with very chronic, even lasting 7 years, leakage from undefined site. Steroid drops as a monotherapy helped in anecdotal 2 cases, but anti-VEGF or triamcinolone did not bring any result. This diagram is showing the classical laser in red line, and the stimulation laser blue line, and you see finally the vision was the same. This is another graph. This is comparing the groups with the focal laser and the stimulation laser. So the take-home message from this is that the central serous choroidal retinopathy can be treated with a classical laser, not only in cases with clearly focal leakage, but even in cases with poorly defined, only anticipated or diffuse leakage. And let me go to the second topic, which is perifoveal telangiectasis. This macular edema with perifoveal telangiectasis is very difficult to treat, and usually the recommendation is observation only, but encouraged by the good results of the stimulation laser in CSC, we use this treatment in challenging cases of telangiectasis. I will show you a group of 12 eyes of 11 patients who had perifoveal telangiectasis of various origins. And we treated them. Most of them was idiopathic. 2 were after branchioretinal vein occlusion. 1 was connected with microaneurysm, and 1 with later developed CNV. This is the follow-up. And vision improved in 9 eyes and stabilized in 2 eyes, worsened in 1 eye where the CNV developed later. The mean visual acuity improved from 0.5 to 0.7. It means 2 ETDRS lines. This is the visual improvement. This is the case with the CNV. And OCT finding improved in all cases, as you can see here. Heart exudates regressed. So this is a case where we had a presumed telangiectasis here, juxtafoveal, and we treated it, and success was gained. Here there was an ectasis here, and after the laser, the heart exudates completely reabsorbed, and still there are no visible laser spots, and the vision improved. This patient was a diabetic, but we did not think this was a diabetic microaneurysm, but rather it was telangiectasis, and it improved after the stimulation therapy. This was a macroaneurysm, but micro telangiectasis were here, and after the treatment, the patient improved from 0.4, improved to 0.6, and lost the subretinal fluid. This lady was allergic to all medications and to all chemicals, so we could not perform fluorescein. So we just stimulated the fovea with subthreshold laser, and we succeeded in one eye reabsorbing the subretinal fluid. Vision improved from 0.5 to 1. But in the other eye, we treated her the same way, but CNV later developed, and there was a drop of vision to 0.05. This case had a branch retinal vein occlusion with lipids, and after the treatment, the lipids were gone, and the vision improved from 0.7 to 20/20 in spite of this vitreofoveal traction. She did not want to undergo the surgery. This was idiopathic telangiectasis in a patient who had hypertension and hypercholesterolemia, and after very gentle laser treatment, improved from 0.6 to 20/20. Idiopathic telangiectasis somewhere here, and the leakage was at this point and presumed at this point. We treated with laser and gained a real success. So the take-home message is even macular edema due to juxtafoveal telangiectasis, previously condemned to observation only, can successfully be treated with threshold or subthreshold laser. The laser spots using the classical retinal laser should be very mild, almost invisible, sometimes even invisible on the fluorescein angiography. And any conventional laser is sufficient for subthreshold treatment. You do not need a special pattern laser for that. Thank you very much for your attention. Shukran.